Hi lovies, you need to get a cup of tea for this one, because this is something that we hope nobody we know has to go through, or it's something we don't ever dream of going through ourselves, but it's something I wanted to talk to about tonight, because this has been very close to my family. One of my sisters has been through this, and now my other sister is going through it. So this show is for information only. It's not a substitute for personalised medical advice. If you have urgent symptoms, e.g. a new hot red swollen breast, or you feel very unwell on chemo, seek medical help immediately via your oncology 24-hour line, NHS 111 or A&E for emotional or practical support. Macmillan's support line is free. It's 0808 808 0000, and they are an amazing charity. So, welcome to the show. So today we're going deep on breast cancer, what it is, how to lower your risk, what to do if you find a change, how NHS diagnosis actually works, modern treatments and practical tools to get you through. We'll keep it clear, science-backed and UK specific, and I'll give you concrete next steps along the way. So let's talk breast basics, plain English anatomy. Struggling to get my words out today. Your breasts are mostly gland tissue. Think lobules and ducts. Fat, connective tissue, blood vessels and nerves. Cancer usually starts in the ducts or lobules when cells grow and divide in an uncontrolled way. Hormone receptors, estrogen and progesterone, and a protein called HER2 help doctors subtype the cancer and choose the treatments. This is why every biopsy is tested for ER/PR and HER2. You'll also hear about lymph nodes in the armpit, first stop for any travelling cancer cells, which is why surgeons may sample the sentinel nodes during surgery. So, signs and symptoms, what to check and when to act. There's no special correct technique. You just need to get familiar with how your breasts, upper chest up to the collarbone and armpits normally look and feel. Then follow TLC, which stands for touch, look, check. Get new or unusual changes checked by your GP. Typical red flags include a new lump or area of thickening, change in size or shape, skin dimpling or puckering, persistent pain in one area, nipple inversion change, crusting or rash on the nipple areola, blood-stained or clear discharge, swelling in the armpit or around the collarbone. If you are at the age where you have a mammogram, they are very, very important, because this is how it's been picked up in my family member. Otherwise, she wouldn't have known. So if it's an inflamed, hot, painful breast with peau d'orange, which is the orange peel skin, and you feel unwell, don't wait. This can rarely be inflammatory breast cancer, so you need to seek urgent assessment. So, screening in the UK, who's invited and how to book. In England, everyone registered with a GP as female is invited for breast screening every 3 years from age 50 up to your 71st birthday. Your first invite usually arrives between the age of 50 to 53. Over 71, you can still self-refer to your local breast screening unit. Trans and non-binary people should speak to their GP or screening service to ensure that they're invited appropriately. Screening uses a mammogram, a low-dose X-ray, to catch cancers before you notice symptoms. Early detection improves outcomes dramatically. You'll be sent your results, and if more views or ultrasounds are needed, you will be recalled. If you notice a change, the GP and the 2-week breast clinic. So if you find a change, book your GP promptly with your concerning symptoms. Your GP can make an urgent suspected cancer referral, and you're usually seen at a breast clinic within 2 weeks. No matter what it is, don't wait. Go speak to your GP. It's always better to be safe. At the clinic, you'll typically have triple assessment. You'll have a clinical exam. You'll have the imaging, mammogram or ultrasound, sometimes an MRI too. A core needle biopsy if needed. This one-stop model helps you leave with a clear plan. So, understanding your diagnosis, the report made simple. Your pathology report will state type, whether it's ductal, lobular, and grade, how fast the cells look to be growing, the stage, the tumour size, and the node's spread. Receptors, the ERPR hormone receptors, and the HER2. The Ki-67 is a measure of proliferation in some centres. For some early ER-positive, HER2 negative cancers, the NHS can use tumour profiling gene tests, Oncotype DX, EndoPredict, or Prosigna to help decide whether chemotherapy adds benefit on top of hormone therapy, available under the NICE criteria, including selected people with 1 to 3 positive nodes and certain node negative cases. So we're going to talk about prevention and lowering risk, which is evidence-based. I apologise for talking about this, but it's important to let people know that there is steps that they can take, especially if they're in the high risk category. So, quick realistic actions that reduce the risk at population level. Keep active and maintain a healthy weight. Physical activity lowers the risk after menopause. Limit or avoid alcohol. There's strong evidence that alcohol increases breast cancer risk, and many charities now advise abstinence for prevention. When you have a baby, breastfeed if you can. It reduces a mother's breast cancer risk. These are from large evidence reviews by the World Cancer Research Fund. I haven't just pulled them out of a hat. And if you have a strong family history, ask your GP about the familial breast cancer pathway for genetic counselling, testing and tailored screening or risk. Reducing options, including medications such as anastrozole or tamoxifen in selected higher risk groups under the NIC Family History Guidance. Treatment overview, the team sport. This case is discussed at a multidisciplinary team MDT to plan care and the main pillars. So at first, the surgery, the lumpectomy, which is breast conserving, or sometimes a mastectomy, often with sentinel lymph node biopsy. Radiotherapy, commonly after lumpectomy, and sometimes after a mastectomy. Systematic therapies, chemotherapy, endocrine hormone therapy targeted therapies, e.g. the anti-HER2, immunotherapy for specific subtypes. NICE's guidelines, NG101, covers diagnosis and management for early and locally advanced breast cancer. So surgery and lymph nodes, reconstruction and lipodemia. Breast conserving surgery plus radiotherapy is as effective as a mastectomy for many early cancers. Your surgeon may sample the sentinel node. If clear, further axillary surgery may be avoided. If nodes are involved, additional node surgery or radiotherapy may be advised. Reconstruction. Implant-based or your own tissue, such as the DIEP flap, can be immediate or delayed. Discuss the pros and cons, including recovery time and how future imaging is done. The lymphedema, arm or breast swelling, can occur after node surgery or radiotherapy. Prevention and management are practical. Keep active. Do physiotherapists taught range of motion and lymph drainage friendly exercises. Maintain healthy weight. Look after skin and consider specialist fitted compression sleeves or bras if prescribed. Specialist lymphedema services, Macmillan and breast cancer, now have excellent guides. Radiotherapy, modern shorter courses. Modern UK practice frequently uses hypofractionation, shorter courses. Many centres offer fast-forward schedules. For example, 5 treatments over 1 week when suitable, with outcomes comparable to older, longer regimes. Your oncologist will explain the best plan for your case. Skincare tips, gentle washing, moisturiser as advised by your team, protect skin from friction and sun, and report any significant redness or moist desquamation early. So medicines that treat breast cancer. The endocrine hormone therapy for ER-positive cancers. Tamoxifen for premenopause and postmenopause, or aromatase inhibitors like anastrozole, letrozole, postmenopause. Typical minimum duration is 5 years, with many benefiting from extended therapy, 7 to 10 years, depending on risk and tolerance. This is an MDT decision. Bone health needs check-in on aromatase inhibitors. Adjuvant bisophonates, e.g. zoledronic acid or sodium clodronate, are offered to postmenopausal women with node-positive disease and considered in high-risk node-negative disease to reduce recurrence and improve survival. Chemotherapy used before surgery, neoadjuvant to shrink tumours, or after to reduce recurrent risk, particularly for triple negative or higher risk cancers. Safety note: if you're on chemo and develop fever or actually feel acutely unwell, neutropenic sepsis is an emergency. Seek immediate hospital assessment. Anti-HER2 targeted therapy for HER2 positive cancers. Combinations built around trastuzumab, with or without pertuzumab, are standard in early and advanced disease. Cardiac function is monitored with echocardiograms during this therapy. For HER2 low advanced disease, not HER2 positive by standard tests. Trastuzumab deruxtecan is recommended by the NICE TA 992 after prior chemotherapy. Ask your oncologist about eligibility and local availability. Immunotherapy for early triple-negative disease at high risk. Pembrolizumab with chemotherapy before surgery, followed by adjuvant pembrolizumab, has shown survival benefit in Keynote 522 and is part of the NICE's evolving guidance. Your MDT will advise if you meet the criteria. Gene tests steering chemo decisions as noted. Oncotype DX, EndoPresync and Prosigna can help decide if chemo is worthwhile in ER-positive, HER2 negative early cancers under the NICE DG58. So, side effects and day-to-day coping. With chemo, you will get fatigue, nausea, hair loss, taste change, neuropathy. Keep up your fluids, gentle movement, small frequent meals. Ask about nausea regimes and scalp cooling activity. Know your 24-hour oncology helpline and act fast for infection signs. If you're having endocrine therapy, if you have hot flushes, joint aches, vaginal dryness or low mood, don't suffer in silence. There are options. Non-hormone lubricants, pelvic health physio, exercise, sleep hygiene, cognitive behavioural strategies, and where appropriate, medicines to ease vasomotor symptoms. Bone health, calcium and vitamin D, weight-bearing exercise and DEXA monitoring are advised. Radiotherapy. If you have a local skin reaction and fatigue, simple skincare and pacing help. Report any strong or persistent reactions promptly. Heart monitoring needs to be done on certain drugs, for example, the trastuzumab. It's standard. You'll have periodic echocardiograms to keep you safe. Special groups and life events. During or after pregnancy, urgent assessment of any breast changes, pregnancy-associated cancers happen and need specialist input. Men get breast cancer too. New lumps or nipple changes warrant GP review. Trans and non-binary people. Ensure GP records support invitations for screening appropriate to your anatomy and hormone exposure. Ask to self-refer if you're eligible but not invited. Practical help, money worries, and what to say to loved ones. If you're struggling with work, benefits, transport, or simply emotions, you're not alone in the UK. Macmillan offers clinical nurse support, a support line. The number again is 0808 808 0000. Benefits advice and local services. There's Breast Cancer Now that provides helplines, forums and clear patient information. Maggie's centres also offer drop-in psychological and practical support for you and your family. Save these in your phone today. They can be your lifeline. You've got this. Your team is there, and so are charities and communities who truly understand. Share this episode with someone who needs it, and remember, touch, look and check. TLC. Thank you for being here with me tonight, and I just wish you the best, and you are amazing. Thank you.